All right. Good morning, everyone. I love this. It's small, it's tidy, more of this family feel. It's definitely which speaks volume to the work that we do, right? Not many people are familiar with it, but it's yet so important and so vital to early childhood. For those, welcome of those that are here with us virtually and in person. And for those of you that don't know me, I'm Danubia Camargo Silva. I'm a Senior Program Officer for Child Wellbeing here at the Boston Foundation. And for those of you that are not familiar with the Boston Foundation is Greater Boston's community foundation. And we invest our resources, relationships, and voice in building a thriving, just, and equitable region where opportunity and prosperity are extended to all. And let me make this very clear. We do not do this work for a community. We do it with community. And today is a great example of that. We enter this work with deep humility and the belief that real and lasting solutions are co-created. It is grounded in lived experiences and powered by collective action. And at the heart of the child well-being pathway, we focus on advancing maternal health equity, integrating mental and behavioral health into early childhood serving systems, and strengthening the early education and care sector. When we center these priorities, we create conditions for our youngest citizens not to only survive, but to thrive and live lives of joy, dignity, and choice. And while I tend to wear rose-colored glasses, as many of you know, holding onto hope and optimism, even in the face of hard truths, I cannot ignore the reality of this moment. We are living through a time of profound threat. We are living where our federal administration is actively working to unravel decades of hard-won progress. And the burden of these attacks is falling hardest on families and communities who have long been denied access and opportunities. But as our president and CEO, Dr. Lee Pelton, recently reminded us, quoting Dr. King, "A time comes when silence is betrayal." And at the Boston Foundation, we will not be silent. We are speaking out and showing up for the communities most impacted. Let's rise together in solidarity and action with our values as our compass and our communities as our guide. We are honored to be joined this morning by someone who embodies that spirit of leadership and collaboration. Aditi Sabmariam, Director of Infant and Early Childhood Mental Health and Policy at the Massachusetts Society for the Prevention of Cruelty to Children. Aditi is a dedicated systems thinker, a tireless advocate, a trusted partner. Today, she'll walk us through the research, guide us through the agenda, and serve as our moderator. Thank you for being here. Thank you for the work that you do. And thank you for believing in the power of community-led transformation. Let's get started.
Oh, good morning, everybody. Thank you for being here. I want to start off by Danubia, what a beautiful opening, right? We are stronger than the I, and that's why we are here both in this room and remotely on Zoom. So I want to take a minute to thank the Boston Foundation, Danubia, Antonia, and the entire foundation for making this collective work possible. I want to thank our partners at Boston University for really walking alongside and co-joining to really make this research possible. And to our panelists who have really are going to join us, and you'll hear from them today, to really center what does this actually look like in community? How do we, not how do I, but how do we move the agenda together now more than ever? And to each of us in the workforce, all of us who are here in this room and folks who deeply care about babies and families and pregnant people, thank you for showing up in this collective. So I want to start us off with really paying attention to when we say infant early childhood mental health and early relational health, right? We are really talking about that developing capacity of the young child from prenatal to birth to 6, to explore their environment, to be able to form peer and grown-up relationships, and to really express their emotions, all within the context of their community, culture, and family. And whether we say infant early childhood mental health, early relational health, if that's our understanding, then absolutely the workforce from that is extending into paying attention to all of us who are a part of the workforce. And so this project grew out of that core understanding that infant early childhood mental health workforce does not only sit in behavioral health and mental health, that we sit across a continuum, almost like a public health model, that is really looking at promotion, prevention, and intervention. So those of us who really serve families from promoting well-being and relational wellness for families and children, those of us who are in the space of really preventing, mitigating toxic stress and impacts of trauma. And there is a tippy top of the triangle, which is intervention and treatment, right? And we would love to keep that tippy top like this and not have it inverted, right? So really holding then those of us in the treatment intervention continuum who are really saying, how do we make sure that intervening early and understanding that we intervene early in the lifespan is also prevention in the long run. So with that, we wanted to understand the assets and the needs of this very unique relational workforce across our state of Massachusetts. And so I am going to turn it to our amazing research colleagues, Dr. Mendez and Jenny, who will walk us through what we learned in the study today.
Thank you, Aditi, for the introduction. So my name is Jenny. I'm the research assistant on our study at Boston University, the School of Social Work. Just to run down, I'll start by talking about our methods and our approach to this study. So largely, we had a very comprehensive approach with the study, starting first with our quantitative survey, where we were able to get feedback and responses from direct care providers, those who work directly with children and families with children birth to 6. And then we went into our second phase of our study, which is our rapid analysis qualitative interviews, where we were able to interview supervisors, managers, program leadership on workforce needs, what they see in managing their programs. I think I've spoken with many different supervisors in this role. And then we were able to kind of gather that data and create this comprehensive results here. So a part of the quantitative aspect, we were able to gather the results from direct care providers and create a systems map where we were able to inform what types of infant early childhood mental health services from the promotion, prevention, intervention spectrum, and how those sit within Massachusetts to help us better inform what types of needs exist in different communities and the assets that also sit there as well and how we can uplift those. So diving into our results, with our demographics, who's represented in this study. So in our first our first phase of our study, we really dove into hearing direct care providers' voices. We had a total number of 91 respondents to our survey. And the majority of those direct care providers represent the Metro Boston area, identified as women, identified as white, and were educated with a master's degree or higher. So our sampling really came from resources in our collaboration with MSPCC, the hefty listservs that exist. I'm sure many have gotten emails. And from there, we were able to kind of identify key points of contact and continue on with our snowball sampling through those resources. I'll pause for a second. This is a lot of information, but as I stated before, you can see how our demographics sit in the respondents that we had to our survey. Something to note is in our Massachusetts region of practice, some respondents stated that they worked in multiple regions or statewide, so they're represented multiple times. So our total number of respondents there will be greater than 91. So I'll give you a couple seconds to kind of frame your understanding of our respondents and our demographics here. All right. So from our quantitative data, we were able to create an interactive map. I'll give you all, our interactive map really came from our direct care providers' input. We were able to map out people's responses to what they're trained in, what they desire in training, the type of supervision they receive, and what specific types of services they provide in their area. So I encourage you all right now to scan this QR code and play with our map. Wonderful. Okay, I'll give a couple more seconds here. The glare of the screens might make it hard to scan. Okay. So I would recommend, it's a lot of data to unpack on our little map. Unfortunately, I was playing around with it on my phone yesterday. Some of the features don't pop up on mobile version, so I would really encourage you to, after our presentation here, to open it up on a desktop. But I think what I would recommend in exploring our map is to first unclick all of the checkboxes on the side. And depending on what brings you here today, what you want to learn more about from our study, click based on your own interests, right? So the categories are organized by service. So the promotion and prevention end of the spectrum, we have the providers who are trained in those services and providers who desire those services. And then those are grouped kind of down the line there. When you, on the desktop version, you should be able to also expand and see all of the agencies that are represented on the map and click through those specifically to even see what providers have responded in the specific types of services that they actually provide in those. So I'll give you all, a couple minutes to explore on your own. If it plays. I'll count down in my head. To kind of explore on your own, see what you see, and then I would love to hear just initial observations and any wonders. We won't really take the time to discuss, but I would love to see what pops up for you immediately. And please talk with your colleagues. Take the time. Of course, yes. If the QR code isn't working, you can also type this link directly into a web browser. All right, so this presentation will be made available for you. The link is also in our report that I believe most of you received. I would love to hear just initial, like, what did you see? What do you wonder? Just a couple of responses if you would like to share. Maybe we need more time to process, but that's okay. Okay, so I'll just go ahead and dive into, oh yeah.
So it looks like, I mean, this isn't uncommon in our state where there's like, you get kind of this, a lot of stuff in Boston and a smattering of some stuff maybe in the, in Springfield area, but then there's a big desert, it seems like, in the central part of the state. So yeah, I could notice the gaps and where we had some.
Definitely, yes. I saw a hand as well.
I'll pull it up on my desktop, but
Mhm.
I wanted to better understand what was your goal in creating the map. I think that's very useful, so thank you for doing that. But what was your goal in framing and creating it, so you have that in mind?
Definitely, yes. And we'll dive more into those richer discussions as we move on in the presentation. So thank you for bringing that up. Yes.
I think what is interesting to me is, I also noticed what Kelly noticed is the central part of the state, but also the diversity of, the diversity of organizations. That they're not things that you necessarily assume have early childhood focus in any way.
Definitely.
So that was kind of a nice thing for me to see. Yeah.
And really building that system of care that we're talking so much about.
Yes.
Okay. Great. So to dive a little bit more into our quantitative results here, just to kind of see side by side the data that we're receiving and then how it's represented in a map. So out of those who are responding in these pins here, these are the specific services that they are providing, the service providers that are represented in the map. So we see home visiting, family support, parenting support, parent-child playgroups, and other. What's interesting in these results is to see that drop off in the parent-child playgroups, especially in the Boston region where we see most kind of stay at the same level, and then there's a pretty steep drop off for that service there. So each of these are grouped by specific type of service, and then each color represents a different region that we got these responses from. And these are our prevention responses. So the types of services that direct care providers are servicing in the prevention side of the continuum, with the majority of respondents in the mental health consultation field, and then less in early intervention and integration in pediatric primary care seems to be a pretty big need in our results here. And I would like to point out other is specified by our respondents. They were able to type in their specific responses, so those results are in our report. I implore you to dive into that on your own time as well. And then in our assessment, diagnosis, and intervention end of the continuum, we see that there's a big need in the substance use treatment area. 0 direct care providers responded as having these trainings in Western, Central, and Northeast Massachusetts. This doesn't mean that families in those regions do not have substance use disorder experiences, but rather a lack of community-based care. And this makes me wonder how far families are traveling in order to engage in the substance use disorder, IECMH type of programs. So this drop-off here is really important to notice and a big takeaway in our study as well. And we also see, just based on the colors that you see, there seems to be a lot more respondents sitting in the prevention promotion end of the spectrum, and maybe we, in our future studies, can kind of expand our network of respondents to make sure we're representing the entire continuum in our study. And then in our questions about what type of professional development do you desire? How do we move forward? How do we support your workforce in expanding these services? With all of the trained in categories selected, we see where most of these trained in individuals sit. Similarly to what Kelly mentioned earlier, we do have a big concentration in those major cities, but then we see pop-ups of desires where we don't have people trained in those areas. So for example, up in the northeast side, and then a couple of regions here where we don't have respondents saying they're trained in these services, but they do desire the professional development. And we see across the board, people desire professional development in all aspects. And barriers. So this is a very important part of our study. We want to understand what's keeping our providers from accessing these trainings. The most prevalent response here is affordability. So we need to think about how equitable funding for training is, whether or not it's sitting in these large agencies, and how our direct care providers are accessing trainings who don't necessarily work in these agencies. Are they being publicized to people who are in independent practice? And how are we making sure that access is available all around? Our next most prevalent response is lack of ways to access training. From my own personal experience working in community-based mental health, there are so many interesting trainings that pop up, but you have to see a client at 10 and you can't attend a training. How are we able to support alternative forms of accessing these trainings? Those who are in home visiting, lack of office space. How are people going to sit for 2-hour trainings if they don't have space to? So again, our agencies across the board allowing trainings to be accessed to our wonderful providers who are doing these creative service, can't think of the word, service delivery. There we go. Okay, so now I'll pass it off to Alicia for our brief qualitative results.
Okay. Hi, everyone. All right, so I will just briefly go over this, right? I want to talk to you about who we interviewed. Again, these are people who were primarily in leadership roles, kind of supervisory position. And I think it's important to note that our supervisors are really representing what we see demographically in the direct care providers, meaning that these are primarily white women who are in these supervisorial roles, as well as who are part of the direct care providers. So that's just something to keep in mind. As we go on, I'll eventually talk to you about the limitations, recommendations, etc. Of course, there's limitations with that, with who we were able to reach. So for all of the themes, you can see we broke them into workforce strengths that came up from these interviews, needs, and then systems level needs, right? We really wanted to highlight what's going well, what needs work, and where can funders, policymakers really intervene and support this work, because we know that many folks care deeply about this. So I'll go over most of these, but not all of them. And all right, here we go. So the first workforce strength that came out was that reflective supervision is happening, right? This is a relational workforce, meaning that these folks need to be connecting with people outside of this in-person work that they're doing. And they need that support, and agencies are aware of this, supervisors are aware of this, and all agencies seem to be working toward engaging in reflective supervision. What that looks like in terms of dosage, right, how often, when, and where is different, but it is something that is on supervisors' minds and generally is occurring in most agencies. Another thing that came up was that these agencies really are working toward making sure that there's a built-in budget for training, right? We just saw that these folks all have a desire for training, and agencies are aware of this. So they're doing what they can to make sure that they do have access to budgets. Specifically for that. And lots of the interviews, folks were actually listing, we offer this, we offer this, we offer this. And so there's a lot that is offered. But if we look here, this Supervisor 207 is really talking about how because of donations, we can send people to these things. And so that's something just to keep in mind, right? So if donations are not coming in, what does that mean for these? It's not consistent funding that's always available. And I would say one of the biggest strengths of this workforce is the intentionality around hiring those with lived experience. Whether these are people who are part of the agencies at one point who have turned into peer navigators, whether these are people that have just had some form of systems level experience, these are who are the people we want to recruit and are working with these families. And at the same time, supervisors are thinking about what does that mean, again, relationally? What does it mean to have people with lived experience, may have experienced some trauma, and how do we better serve them? And how does that connect us to retention? And for Supervisor 101, they talked about how they are hiring people with experiential hiring here. These are people who've walked the journey. We wanted people on the journey to work with these families. And so now let's talk a little bit about workforce needs. Let's go back to that reflective supervision, right? Yes, it's happening, but folks really talked about us not being there yet. And that simply means that while we're working toward it, really what this looks like, how often this is happening, isn't where it needs to be. Not everyone is getting this. In some cases, people would talk about how, specific types of IECMH staff are getting it, but not always others. Supervisors in particular also need this, right? This is not just for direct care providers. And so this is something that we're continuing to work on in the state of Massachusetts. And you can see here this specific quote talks about how we're not there yet, but the goal is to make it available for everyone doing this work. The idea of really taking care of our staff so that when they take care of families, they're able to be present and whole at the same time. This other idea that came up was this idea of going back to the basics. So I'm sure many of you know, if you're in the field, that folks are entering the IECMH field really with little to no understanding of what it means to be working with families with young children. And that's not unique to your agency, it's common. And that's because we don't yet have really integrated education about this within all of these human service organizations types of degrees, right? And so here we see that this supervisor talked about going back to the basics before going on to the more intentional trainings about trauma or dealing with someone who has a history of expulsions, right? We really have to go back to why is this important? Why are we engaging families? Why do we all need to be doing this? The other need that came up was this idea of more support for providers with trauma history. And you can see that linking to, of course, these are folks with lived experience. So of course they naturally have a trauma history. It's also, likely that folks are experiencing secondary trauma, vicarious trauma as they're going in and out of these homes. And so this was something that came up a lot for these folks. This one provider shared how, but also thinking about people who are in the field who have lived experience too. Exploration of trauma-informed work and grounding in that, I think, feels necessary. And the number one need that came up for folks was just, we need more people. I'm sure this does not surprise you. This was truly the first thing that everyone shared. We do not have enough workers out here. The workers who are coming into the field are not quite ready to enter their field. They could be young people who aren't parents themselves, and that feels like a barrier to helping these families, right? Thinking like I can only have experience if I am a parent, but we know that's simply not true. Right? And so we really need to beef up this workforce. In particular, I like this supervisor 211 talked about how, this workforce is not robust, but particularly for 0 to 6, resources are scarce. And finally, for our systems level needs, how are we going to build our workforce? How are we going to retain them? We have to pay them better, right? Of course, this is an outcome. I'm sure this doesn't surprise you. But this is something that came up consistently. And one provider in particular talked about how these folks can get paid better, potentially working in retail. And this is something that we shouldn't let happen, right? So they talk about pay is another huge issue to both find and retain staff. It's at a point where to really do this hard job that is emotionally taxing, and when you get connected with families that require you to go into all these different environments, and when that someone is still making less than someone who might be working at Target or Walmart, who are not having to do those things, it's easy to lose people to that. And we've got to make sure that that's not happening anymore. Similarly, we also need this greater awareness of racial and cultural awareness. But again, when supervisors were talking about this wasn't just putting the onus on direct care providers. They were talking about this at each level, their own reflectivity, right? Where are they on this learning path of understanding that cultural and racial and linguistic needs are really important? And where are their supervisors on this path? And where are the funders? And where are the boards, right? If we are not all on the same page, that if a family says, I would like to be matched by race and language, we not only want to honor that, but we can honor that, right? And we have a long way to go with that. This idea of secondary prevention came up too, right? When we're thinking about this promotion, prevention, intervention continuum. Aditi really talked about how ideally intervention is sitting at the tippy top, right? But really what seems to be happening is that it's actually on the bottom, right? So we are intervening with families after a trauma has already occurred. So prevention is not primary prevention, instead it is secondary prevention. We are meeting families where they are after they've already experienced a trauma or after they've already met this high need of care, right? And that's where we really want to beef up things like promotion. So again, we saw in Jenny's work that promotion is something that lots of folks are trained in, but they're unable to do it because they have to rely on doing more intervention and prevention services with folks. And we can see here that this supervisor said we're starting with either kids who are in foster care and being bounced around or being kicked out of childcare. So we're starting from a place of let's support this child, stabilize them in their position, whether that's childcare or foster care. And finally, we really talked about this idea of integrating systems, right? This is something Massachusetts has been a leader in and continues to be a leader in, but still more work needs to be done. This supervisor talked about how Massachusetts has been trying to do this. It's creating a system of care that is multidisciplinary and integrated, and I still don't think we do that well enough. We often work quite siloed. How do we create a more integrated rather than siloed system? So putting this all together, the limitations of these results are that these results are themselves siloed, right? We have limited access. We have our folks who are commonly in our lanes who we were able to reach out to. So who we included in this survey, they only represent certain sectors of IECMH work, right? We didn't get people who are working in law. We hardly got folks who are working directly in healthcare, but these are all people who are part of this conversation. And so that's certainly a limitation of this, and we see that in the results, we see that in the representation on the maps. There are, of course, people who are hopefully doing substance use work in those regions, but we just weren't able to reach them yet. And then finally for the mapping, the one thing we want to talk about there is, ideally this map would be a heat map. Each agency who participated, some of them had more than one person responding to these questions. And so there actually might be more of those folks in different regions, but we weren't able to show that with the Google map. Having said that, right, the goal was to make it accessible. Someone had asked about that. We want people to interact with this, look at where providers are trained, who can help them, and are they nearby? So we want this going to all types of folks. And again, we think about this about building the workforce. Can we send this to students and say, hey, like these are all the different regions that you can work at? Oh, push the wrong button. We're good. All right, so for these recommendations, just for the sake of time, I encourage you to please from wherever you are, take a snapshot of these because these are really our take homes of what we want to do together. And because this is community work, we're not done, right? So what this means to us is that these are our recommendations, but we want to hear from you. We want to know, are these resonating with you? What am I missing? What is Jenny missing? What are we all missing in this work? Of course, our number one thing that we're suggesting is we want to increase the workforce. We want to keep people here who have lived experience, and we have to do that through increasing wages, which is going to happen on a continuum, right? Talking about Medicaid services, making sure that folks can bill. But there's more that needs to be happening too, such as accessible training, having one place that people can go to in their downtime, at home, online, right? And then finally, really the substance use need was one of the big things that we wanted to talk about too. While I was saying there's likely folks in those regions that are doing that work, it is still likely that there are a few people doing that work. It's hard to work with families who have substance use issues with littles. It's just hard, right? But this is important work, and we know that to prevent more trauma from happening, we have to be keeping these families together. And so we really need to be working toward training more people in that. And then, of course, integrating more care is our overall hope for this. So our next steps, this is one of them. We hope to present this to more folks who are doing direct care work. And then we want to continue to work toward achieving these recommendations in partnership with other groups who may engage in lobbying. We want to seek more funding to do a deeper dive, a more thorough mapping, right? In my head, because I'm a little bit, I want to use the yellow pages and just call everyone and say like, what are you guys doing with these kids? Because that would be, more effective, or going door to door, right? Like, there are folks doing this work who are not represented, and we would really like to get at that. And then, of course, just thinking about different ways we can invest in this workforce more. So with that, thank you. Thank you so much for your time, and we're gonna move on.
Thank you, Alicia and Jenny, for not just collective recommendations, but also this work doesn't end. We want to really dive deeper because we absolutely have missed the promotion, prevention, intervention continuum. There's a lot of people who we did not reach in this first study. I am going to turn it to actually invite our panelists on stage, I was going to say. So Christy Mowlin, Dr. Fumia Gosha, Megan Simbor, and Andrea Oliveira. All right. Thank you all for, can you hear me? Yes. Oh, this is magic. All right. Thank you all for being here. And I'm going to talk less, and I would love to hear from each of you. And so maybe we'll start with going just this way. And so Megan, we'll start with you. So I invite each of you to share what brought you to this work. Everybody has their professional bios, right? So you could read the professional bios, but what brought you to this work? What heart brought you to this work? And help us understand from your perspective who the ICMH workforce is, or who the early relational health and infant early childhood mental health workforce is.
Yes, so Megan Simber from Community Teamwork. And Community Teamwork started developing behavioral health services in the last 3 to 5 years, primarily because we saw a lot of our children were at the tippy top. Our pyramid was upside down, and we knew that we needed to adjust our approaches, and we needed to start looking at how we were supporting children and families differently. I think in that, our classrooms, and also, so we have a mixed delivery system, family child care, center-based care, as well as out of school time. Our classrooms and our provider homes were looking very differently as a result of those needs of the children. And so we needed to adjust, and we needed to be responsive to our educators, making sure that they had the tools that they need to provide programming and education and care to all of the children. And we couldn't do that in silos. We had to pull everybody together, and I think that question of who are our infant early childhood mental health workers, it's social workers, it's family service workers. We have interns that we're bringing in to do the work because we're having a hard time finding qualified social workers. It's our educators, it's our center directors, it's our family child care providers. It really is a broad array of professionals. And I think in order to really do justice for children and families, we have to support the entire system, and that's why we're in the work.
Megan.
Thank you.
Fumi.
All right, good. We're still in the morning time. Good morning. Thank you all for the opportunity to be part of this conversation. One of the things that is really critical for me that I believe in is that promotion and prevention start at an early age, right? We have to do what was just said earlier in terms of flip the dynamics of understanding that if we don't get to our young people early, we're going to be doing more work in the space of treatment. So the Office of Behavioral Health Promotion and Prevention started its inception in 2014 during the opioid pandemic. A group of legislators came together with community leaders as well as experts in the field of behavioral health promotion and prevention, came together to really look at what are some of the root causes around behavioral health promotion and prevention across the Commonwealth. And one of the things that was found out is that we did little or no spending. At least 1% of our spending goes into prevention work, right? And so the need to begin to think about how do we expand this work. And so a commission was birthed out of that, and it's called the Commission for Behavioral Health Promotion and Prevention. And from that commission, there were asked to really take some deeper look into this work from a policy reframe perspective, and came the inception of this office. So this office was written into mandate in 2022. And so one of the things that we think about when we talk about the ecological model or the social ecological model is the intersection between the government, the community, organization, families, and individuals, all right? And so this office is helping to create that. But I would say that I'll give credit, right, to our legislators, that really see the need. Things stems from a governmental space, gives us a better, I think we have greater shoulders to stand upon when we have that level of backing. In my view about prevention, and I'll use this analogy, right? Rather than pulling people out of the river downstream, we want to understand why they are falling into the river in the first place, and create systems and structures and landscape that ensure that they don't fall. This is what this office is intended to do, right? Create the investment within prevention work. And this is really centered in our mission to promote mental health and behavioral health wellness, reduce stigma and inequalities, strengthen systems, and support that will help our communities thrive. I often start, when I talk about this office, I talk about imagine a commonwealth where our communities, and including our young people and our caregivers now, thrive. I think we should take a minute and just imagine that, and what will be necessary to do that. And that is the work that this office is intended to do, to create partnership that will help us build the landscape around prevention and promotion. So, thank you.
Thank you for me. I'm so appreciative for really, again, elevating not just survive, but thrive. Like, what does it look like for thriving? Andrea?
Yeah, good morning, everyone. Let's try to answer the two-part question. What brought me into the work, my background's in clinical health psychology, working and particularly with children and families, but as you guys mentioned in the presentation, for the most part, that always means older children, right? Like academically, we go to school and we are talking usually about older kids. We go to work and we're working with older kids. And seeing particularly after working in primary care, the potential to intervene so early when that family is vulnerable and has a newborn and has so much potential for change and is craving support is really what made me fall more in love with the early infant and early childhood mental health field. Who's the workforce for me is really everyone. Anyone who is interacting with a family that has young children is an infant and early childhood mental health provider. Because again, they're in this vulnerable place of life where your words matter so much to them and can have such a huge impact. Any of you that may have kids that interacted with someone that said, oh my God, you're doing such a great job, like that small sentence when you maybe weren't feeling like a great parent, you probably remember who that person was and you'll never forget that person. So I think that everyone who's interacting with families is our workforce.
Thank you, Andrea. Christy?
My turn. So I also thought about this as a question of what is my origin story, and went down the rabbit hole of I'm a middle child from the Midwest, from generations of MAP dwellers. And it's not irrelevant to the conversation, right? Like where we come from is so important in this work. It's important in the work of the workforce, but a different rabbit hole for a different tea party. My current day job is collaboratively building a system of service delivery that can be sustainably implemented without crushing the souls of the workforce. That's my day job, right? That's easy. We can do it. I sit in community-based behavioral health for the last 2.5 years. I came from public health. So once a public health professional, always a public health professional. And also, it's so interesting to sit in the community and in the agencies that are trying to really implement this on the direct service level. And I agree with Andrea, the workforce is boundless. Everybody matters. Everybody who touches a family with young children matters. And also, my day-to-day Center for Early Childhood workforce is, let's say, up and coming, right? They're young or they're very seasoned and coming into infant and early childhood mental health with a lot of lived experience. And this is a really big difference from what we saw 10 or 15 years ago. We used to think of infant and early childhood workforce as the people who have been in the field, who know social work, who know clinical practice, and now want to specialize. That's not what we have. We have people who need to learn the basics, the foundations, and specialize. And we're still figuring out what that means and how to best support that workforce. And the last thing I want to note is that the people I manage and pour into are going to be gone in 2 or 3 years. And that is not that's not by mistake, that's by design. They are meant in their career trajectory, about half of them are meant to come, land for 2 years, 3 years, and then move to the next thing because they're figuring out who they are and who they want to be. And as a program leader, I've come to realize that I have to build around that reality. We have to recognize that we're in a relational field, but people aren't going to stay, and that is a paradox.
Ooh. You know, and I think each of you really elevate this part of like who we are and how we are impacts what we do, and the part of in a relational field, Christy, like what you're saying, how do we then integrate sticking relationships for families, right? And I always think about like, yes, our job also is actually to get ourselves out of a job so that families and babies can thrive, right? So I'm actually going to, Megan, turn back to you, and you know, with your perspective in Head Start and early education and care, can you share how the recommendations from the report might, like maybe 1 or 2 ways that can shed a light on what this means for the specific workforce that you serve?
Absolutely. I think this report just highlights the complexity of infant early childhood mental health consultation. And I'm really excited to see it and grateful for the hard work that was done on this, because I think it really is going to help bring some clarity and understanding and really help us navigate the various funding sources. All programs have different regulations. I think all of the pieces of this infant early childhood mental health system has its own operating system. And really, how do we find ways to pull everybody together and navigate it? Like, I even think when we started our work, you know, I didn't have a map to look and see who I could reach out to when I was connected with Christy, you know, through word of mouth. But having this map is going to be really instrumental in that. And I think, I mean, all of the recommendations and I think all of the findings really do resonate and are aligned with what we're experiencing as a child care provider across the mixed delivery system. But a couple things that I want to point out is in the professional development. The barriers that were up there, the primary barriers for professional development are huge. We can do all the training in the world, but if our workers are not able to implement, to practice, to reflect, reflective supervision is huge. And our workforce, for educators, we have high turnover, talking about, I mean, yes, it's just the way of the world. We have to really find a way to institutionalize and make this training a deep, deep part of our culture and onboarding, so everybody eats, sleeps, and breathes it, really, because that turnover is hard. But then making it accessible, you know, we know there's a crisis for early childhood educators today. In order to have enough coverage in the classroom that is continuity of care, responsive care, we need double the staff that we used to enable staff to come out of their classrooms, to engage in this work and to engage in reflective supervision. So I think that's a significant barrier. And I think the other component that I want to highlight is just the partnership and the collaboration and the coordination of care system. Being a Head Start provider, we're in a very fortunate place. We do have a multidisciplinary team in which we're able to support in partnership with our early intervention, with our public schools. We have contracts for mental health. We have contracts for occupational therapy, speech therapy, ABA therapy. But there's still players missing. And I think our work now is really expanding out and developing relationships. We can't do the work alone, whether it's promotion, prevention, or intervention. We need to develop those partnerships with our community-based health centers, with private mental health providers, and with our primary care systems. And I think part of why that is so important to the work that we're doing and needing to develop this is when we think about a family who's experienced trauma in a child, primary care, right now they're coming to see us in childcare. They might be homeless, experiencing homelessness. They're seeing a caseworker, they're going to a doctor. That's very overwhelming. Having everybody at the table at the same time, everybody has all of the pieces, and seeing all of the pieces, the family then understands better. But I think it also, if we're able to create this broader coordination of care, I think it's funding. You know, when we're really looking at sustainability of all of these efforts, it's a lot of braided funding that is going to be critical to make it happen. And I think one of the recommendations that I really loved seeing is looking at this, because how do we engage differently with Medicaid and with all of the various systems to make the work that we're doing billable services? So I'll stop there.
Thank you, and you're actually leading up right. For me, you shared with us also earlier, right, the social determinants of health and social determinants of mental health. Where does promotion and prevention sit? And you know, we know from literature and studies that return on investments, like ROI, for intervening early and supporting families and young children is prevention in the long run. And so would love to hear from your perspectives of ways that maybe the Office of Promotion and Prevention can support this work really in that perspective.
No, absolutely. At the core of the responsibility of this office is actually to provide funding, right? To provide funding that is targeted towards early promotion and prevention activities. And I love what you said, Megan, that it's really critical that we look at this from the place of collaboration. And so one of the things that this office has done in the last 10 months of its existence is really taking a deep dive into what is currently within our landscape across all of our state agencies when we look at behavioral health promotion and prevention, right? And then taking another step in understanding what are the needs from our community-based organizations. So we did a request of information to get additional data to help us understand what is the current need, right? It's so easy to just pick a need because it's important. I don't think any of the needs that might come across the office is not critical, but it's really important that we hear from our communities because we're doing this together in partnership, right? And then we moved even further to do listening sessions earlier this month, right? With the goal that we want to hear from the people, and we'll be sharing a bit about a link that would give you all the opportunities to actually provide your insight to that later on. And so the way we are approaching this is that funding, this office has a behavioral health trust funding through the Vaping Trust, and that is what is helping us to be able to run programming initiatives and campaigns as well. I think during one of the presentation, one of the recommendation was to provide, I think Alicia was the one that said that, to provide some campaigns to educate our young people around how can they come into the space of behavioral health or healthcare in general. That's some of the things that this office will be able to fund and create more awareness around that. We're going to be funding a lot of campaigns to really amplify that primary level of prevention work. To the point, that was mentioned earlier, is we need to flip our prevention work, right? We shouldn't start from the place of intervention, treatment, right? If we can put additional funding into the earlier work, then we have opportunities for more success down the line. One of the research has shown that 1%, $1 spent in prevention work helps to bridge almost $3 per individual in terms of treatment. So this is, some of the functions of this office that is intended to do. So we will be providing additional funding. We'll be looking at what is existing, like I said earlier on. We will be promoting evidence-based practices, but we also recognize that within some of our communities that we have to pay attention to evidence-informed practices. So looking at some of our marginalized communities where the intervention might look different, and we need to create room for those and fund those kind of interventions too as well. Workforce is critical, right? The office has a key responsibility, not just providing education and awareness, but looking at the mental health conditions of our workforce. So there is attention that is being paid to this in terms of making sure that we're well, right? We're doing this work day in, day out. You talked about people exiting, the field because now they're in that space of leaving the workforce. Some of us have been in this space for 30, 20 years doing this work because we love it. At the core of who we are, we want to help people, right? And so how do we make our workforce well enough to continue to do this work and also find the joy and thrive within the space? So that is my heartbeat for this work, actually, because as I would share that even I have extensive background in the behavioral health field. I'm also an OD practitioner. So understanding people is part of who I am and the core of who I am. And so really infusing that, into the work that will be coming out of this office. And finally, on data, I'm just so blown away by the data that was presented today. That is adding data to what I need and to what the office needs to be able to do the work. And so taking a data-driven approach in terms of how we invest. What are the communities that actually need this funding, and be able to target those funding to those communities and to those geographical areas. So I will pause with that. Thank you.
Thank you, Fumi.
Yeah.
And I think you landed us to really pay attention to that workforce wellness. And Christy, I wanted to turn to you in your role in leading community mental health. And once a public health professional, always a public health professional, and they're not divided from. But within the role of community mental health, including lived experience professionals and clinicians, where do you see gaps and opportunities from this report?
Yeah, I can do that. So, it turns out that community-based behavioral health is really hard. And I don't say that because I didn't think it was hard before I got to it, but it's lived experience, right? Until you're sitting with a budget and thinking, there's no way that math is ever gonna math. It's just not possible. You don't realize it, right? So there are 4 things that I wanted to pull up from the results, and also that I wanted to stay actionable. So if I start to get too far into the that's not possible, pull me back, bring me back to it. So Medicaid, we love soft funding in Massachusetts. We do such a good job at getting grants, at having foundations that support the work of our community, and also we need a system that isn't going to cycle through every couple of years. And in this state, Medicaid and health insurance is ubiquitous. Everyone has it, almost. So we need to figure out how to use it better. And the outpatient behavioral health billing codes, they can cover the whole spectrum. They can be promotion level, prevention level, and treatment level for one child over time, or for multiple children all at the same time. So I want us to really think about how do we come together as a group of people who can figure out how to make outpatient work better for infant and early childhood mental health populations, in addition to children's behavioral health initiatives. So not instead of, right? We need CBHI services to work for little kids, and we need to include in that, spectrum's not the right word, but continuum. That is the word I was looking for. Thank you, Aditi. Second is the infiltrating higher ed. The report calls out curriculum, but I also want to call out internships. We had 8 clinical interns from social work and mental health. Thank you.
We are one brain.
Right? I'm right here. And maybe 8 is overly ambitious. I won't have 8 next year, I'm not gonna lie. But we have to invest in interns, and it is expensive. It is not, it's a short-term investment for an agency like the Home for Little Wanderers. It's a short-term investment that we may or may not see the long-term outcome, but it matters to us that our system has more well-prepared clinicians. And don't let anybody tell you that it's a money-making thing, because the reimbursement you get for an hour of an intern doesn't, again, the math doesn't math. It's not nothing, but it's not making money. Third, yes to lived experience, and a focus on infant and early childhood mental health or development experience. So until I was a foster parent, trying to figure out if I needed urgent care or ER or just to calm down and let the kids sleep, I didn't realize how hard it was to be a parent and to figure out which system do I need to navigate. I just really want us to think about how hard it is to navigate all of our systems for well-being of children 0 to 5 or 6 or 7 or 8. And I also want to point out, which I think, Alicia, I think it was you who said, it's not just about lived experience of parenting, it's about lived experience being a professional in the field. So a couple of my staff worked for decades in early education and care. They are the best people to go into a classroom and say to an educator, here's how to manage this class of 5 dysregulated children, because they've done it. And that lived experience is just as important as the personal. And finally, recommendation number 2 about reflective relational supports and how important they are. So we're in the early stages of putting together a early childhood workforce warm line. And I really think it's going to be another way that we can deliver reflective relational supports in a very broad fashion for everyone who's working with young children and their families. So it's a new project funded by the Boston Foundation. So if you're sitting there thinking, I don't know what Christy's talking about, no one knows what Christy's talking about. But now you know. And be on the lookout for more information, because I'm not going to be able to do this without, I shouldn't touch my mic. I'm not going to be able to do this without a lot of help from people out in the world, in this room, in the, I don't know where the cameras are, in the Zoom room. And also don't wait for me. Reach out to me if you're like, Christy, I want to know more about that now. Because we have to do better, and we have to think of more creative ways and more financially feasible ways to keep reflective supports out in the community.
Thank you, Christy.
You're welcome.
Andrea,
I will be very brief.
lean into it. I think, really that part of workforce, and you sit in really leading interagency collaboration across state agencies and state partners in leading policy and workforce development efforts. Just to what Christy said and how you would add in your perspectives in sustaining infant early childhood mental health workforce development efforts.
So I actually will borrow from both my sides, right? So one, data is so important, and because we have lived in this scarcity of funding, it's not always a priority, because we're investing in services because we need the services, we're investing in workforce development, but then we also need this data. And I'm so thankful for you guys here at the Boston Foundation for having supported this project, because now we have real words to what we see and hear, right? So we can go back and say, this is what people need, this is what people are asking for, and how are we going to do it? Which then brings me to my colleague to the left. We've been really good about funding things with a lot of grants and a lot of one-time donations and funding from philanthropy and even from state agencies. We have braided funding in the past. What has been lacking and what we really need to do strategically moving forward, considering everything that's going on right now, is how do we make it sustainable? Not like this year I can pitch in this amount, that year I don't have anything to offer, right? So how can we all come together and really think about, because the infant and early childhood mental health workforce is everyone's workforce. It's not DMHs, it's not DPHs, it's not, right, EC, it's everyone. So how are we all going to come together and have a sustainable funding stream for workforce development training-wise, but also for sustaining the workforce? So how are we going to incentivize reflective supervision practices? How are we going to incentivize people to go to trainings? How are we going to make sure people are actually implementing the trainings that they've been going to? And how do we support them in doing that? We try with a lot of the trainings we do, we always try to pair them with reflective supervision and case consultations, but they still need more, right? So how are we going to intentionally do this work together moving forward in a time where the scarcity is even bigger now than it was before? So,
Thank you. Each of you are elevating now more than ever. How do we really hold abundance in this collective work, looking beyond our boundaries and service? Could I do one last prompt? I'm looking at our funding.
We're going to go into Q&A. So
Okay, very briefly, given the current climate we're sitting in right now, right? In maybe a phrase or few words to each of you, what would be a North Star in this work for you? Because we have to not stop dreaming and imagining, right? We have to know that the horizon is ahead in this collective work. And so what would be a North Star in this work from your perspective?
are we going in order?
Just
No.
popcorn.
Okay,
Go
I'm happy to go. My North Star is how I started. What I wish to see is that a family, no matter where they go for services, may it be DTA, DCF, private services, that they're always interacted with in a similar fashion with people that have been trained and understand child development and families and trauma and all of the above, so that their experience anywhere they go is supportive, right? I'm not saying everyone should be trained clinically. I'm saying everyone should have the opportunity to interact in a way that is minimally restorative for them. The other, can I just say one more thing? The other thing would be to really start seeing those little P moments around reflective supervision. How do I incentivize this? How do we incentivize a workforce that is so specialized so that they stay, right? Because it is hard work, and they're good at what they do. We want them to stay. And then finally, how do we get to the regions that are missing in the map, right? So I'm thinking that there are a lot of trainings that we do virtually, and yet we don't see them in the map. And this is a complete extrapolation here, but I'm thinking that the regions that have infant mental health work groups were better represented. So Western Mass, Southeast, and Boston. Mm-hmm. So more work for us to do.
All of us. Yeah. Anyone else want a popcorn?
I'll jump in and say, I think one thing that we have to hold on to is how hard this work is. And we need to figure out how to articulate that so that people understand why it's special to be working in infant and early childhood mental health. And I've spent a lot of time trying to think about this and explain it to my supervisors and my program directors over the years. And the best thing I've come up with is it's a mix of evolution and socialization. Because as humans, we only exist if our babies grow up to be independent, right? So we're all like in our DNA, it's in us to say, is that baby okay? And when your whole job is knowing that the baby is not okay, it's not okay, it's not okay, that's just constant wearing on how you are meant to be as a human. And then we get all the messaging through media, through social media, that babies are so cute and cuddly and we should be loving them. And when your job is, again, not to love on them, but to fix the problems that are preventing their families from being able to fully love on them, that's really hard.
And I think that my North Star is the stories. I think really when we look at data is really important. We can see outcomes, inputs, and outputs. But when we hear a story and an anecdotal story and see a family go from crisis to thriving, that's why we're doing the work that we're doing. And I think those stories being told is really important and will rise above any rhetoric. And I think keeping that at the forefront is why we need to keep doing all of this work, right? We need to definitely keep the conversations going. We need to, look at making policy change. How do we look at the systems and not think of them in what they are, but think outside of them? What could they be, and how do we drive that? And it's those stories that help me do that.
And leaning into Megan's description here is, for me, is the word hope, right? The hope that we can shift the narrative of our young people, our caregivers, to a place where they can thrive. And that's what I'm leaning on, that we have data support now, we know we need to do more. We have an office like the office that I'm leading to expand behavioral health promotion and prevention. So there is hope on the horizon, and leaning into DMH's core foundation and pillar is hope, equity, and service. And so how can we continue to really expand on that? So thank you.
Thank you. Thank you to each of you. A round of applause for our panelists. I think you can stay. Each of you really elevated, perhaps we return to all of you, elevated for us as part of both heart work and hard work, right? That spirit of both and I'm struck by, and I'll end with this and return it to all of you for prompts and questions. There is one of my mentors in the field had shared this phrase, learning, understanding, from an indigenous Maasai tribe, which is really that your greeting to one another is, even if you're not a birthing parent in the community, is, how are the babies? And if the babies are well, we are well, our societies are thriving, our tribe is thriving, our communities are thriving. So this is all our business, right? And so with that, for this ongoing collective continued work, we want to turn it to all of you for prompts, questions, wonderings, and if we could do a raise of hands, and then we have amazing mic walkers, runners. Antonia, thank you. All right, so let me see hands. Okay, so maybe we'll go here and then there.
Thank you, everyone, for a wonderful
Introduce
conversation.
yourself.
Yes, Alix Rivière, Massachusetts Office of the Child Advocate. I am so interested in the recommendation to create a one-stop hub for receiving ICMH professional development. And my question to the panelist is, how do we do that? How do we operationalize at a statewide level? Where does it sit? It would solve a lot of issues, but I'm just kind of wondering about your vision for that.
Juan, if you want to answer.
I think that it's a really great question, and I think the barrier to solve that issue is the same as sustaining funding, which is we're all trying to do the best work with the funding we have. So obviously there would be competing interests for for sustaining something like that. But I think at the end of the day, I think this conversation isn't over. I also think there's so much value to regional stops, not just a one stop, because that's kind of what we have right now, right? You know, you get that MassAIM newsletter with the upcoming trainings. So I think this is the starting point for further discussions on how we do this work, and where all of your input will be necessary.
Yeah, and I think about it from the back end, right? If for as much as for families to navigate the system, how do families navigate it? We are all in the workforce. How do we navigate where to get trainings is also as complicated. And I always think, like, if the front is like, yes, this is the one stop, but at the back, the systems are working hard to figure out what that braiding and the collective looks like, then that's on us, right? But for the professionals, what does that look like up front, whether I'm sitting in early education and care, or home visiting, or family support, or clinical work? How do we create a way that is either building upon what we have already and really pulling the curtain and thinking about it and reimagining? But that's why these recommendations are not set in stone. We want to learn from all of you to think about how do we do this, and how do we do this in right relationships.
I think I would also add to that by saying that one of the things that I've learned earlier on in this is when we're taking a population level approach to an intervention, we also have to understand what is happening from a regional perspective, right? So it's good to have a wider net in terms of how we're intentional about this, but what are some of the regional perspectives that we have to consider? Like what's going to work for the urban cities is going to be different for how we approach it from the rural, right, in terms of accessibility. And so to that recommendation, I think it's great, but to everyone's point in terms of how do we work together to really operationalize that in a way that is meaningful for the people that will be accessing those information. Yeah.
Alicia.
Hi. Is it on? Okay, cool. I would say one of the things that we're thinking about, with, Dr. Ruth Paris is also part of this project, and this is something she's been working on and thinking about for years as someone who's lived here for a long time. And so we're really thinking about it in an educational way, right? How do we get other universities, private, public, to work together? Because we have the ability to provide online platforming. We're represented regionally, all private and public universities, to provide this for folks. We are often really embedded in the community. And so that's one of the ways that we're thinking about it is, starting, whether that's with Boston University or whomever, really sort of having a landing pad, and then just, adopting that in other universities, other colleges, community colleges, just so people have access to this within their community, so they don't have to travel for it very far. So they're learning from people who live where they live, right? Because that means that their understanding of their community is going to be different than BU's, right? And so that's one of the ways that we're thinking about it. I will say, like, all of these recommendations are kind of already being worked on. Massachusetts is a leader, again, in integrating care. And so this example is something I just wanted to share, that I know that Dr. Paris has really been working, and with Aditi, right? Like, they're constantly scheming, how do we do this? And so that's just one idea.
We're all in this together.
So I just wanted to add that, because I think it's important to note that we are schemers, and that's what we're thinking about. So that's part of where that comes from as well.
Hi, good morning. I'm Laura Sinelli from the Rennie Center for Education Research and Policy. Thank you all so much for the conversation this morning. I had a question about the Executive Office of Education's recent contract to put together a birth to higher education mental health framework. I'm just curious if any of you or your agencies have interacted with that process at all, and if so, do you have any hopes or thoughts about how that might kind of direct the future for professional development and training in the field?
I have been to one of their meetings. I'm not the point person. I was there to help someone else from our agency that couldn't attend. They're still in the very beginning stages, so I really don't have an answer for that question. I do know that they're trying really hard to reach information from everyone, right? So right now all the state agencies are represented. They're creating a list of stakeholders that they want to reach out, both for information, for research, for community. So it's real, like there's been 3 meetings. So there's not much to report yet, but yeah.
And you know, I think that's where I'm always like, how do we all as a collective hold babies in mind, right? The behavioral health framework is so important, and we know it's the whole span. And so I think as an invitation, like whoever is at those tables, to make sure that we're always elevating the birth to 6-year-olds, early education and care, family, childcare, like all parts of mental health sits in all these systems too. Sometimes I think, you know, I feel like we all know it's everybody's business, but sometimes I realize we're all sitting in I'm sitting in some sort of bubble sometimes that, you know, they're like, oh, mental health and babies, like, right? But we're really saying, like, how do we elevate that this is for all of us, that within that framework, babies and families and the workforce that's serving babies and families are right here. Anyone else on the panel wants to respond? Maybe one more. Yeah. Oh, Danubia.
This question is for Christy, because when we're planning for panels, sometimes it's so quick. But in addition to integrating mental health in the different systems, can you tell us a little bit more, how are you thinking about integrating mental health in early education and care?
I could talk about that all day long. You know, I think we're trying to think, there's so much good work that's happened in Massachusetts, right? We have a great foundation. We have mental health consultation grantees that are out doing work. And what I'm trying to figure out is, how do we fill the gaps that still bubble up? How do we respond in a systematic way that doesn't only bring people who know somebody to call into a solution? And so I think we have to be proactively in early ed spaces and saying to early educators and to families with children in early education settings, what's not working, what's working, what do we see them doing right? How do we pour more positive optimism into a workforce that's really down, that's working really hard and struggling to do really great work? What I don't think we do is villainize early education and care. I don't think that we throw the baby out with the bathwater, which of course is a terrible phrase, but so appropriate here. That we, and this sort of answers other questions too, because I always get really frustrated by how this happens, that we forget the lessons that have been learned before us. So we have, we've learned so much in this state. People who've been here longer than I've lived in Massachusetts and doing this work, how do we keep building so that we're not doing the same old thing or doing a thing that didn't work before and just thinking that because we're doing it, it's magically gonna work this time. But how do we really stay fresh and engaged? That's part of it.
Thank you. Thank you. I'm actually going to, we're going to linger for questions after, but we want to actually close and turn it to Dr. Ruth Barris to share a few comments with closing.
Hi, good morning. Still morning, yes. So I am just beyond delighted for being here. So I've been so appreciative of being able to listen this morning. And so though I'm listed on there, I'm really like a supporter and a cheerleader and a little bit of a consultant on this project. So I want to thank Aditi and Alicia and Jenny for their incredible work. And as so many of you have said, providing these data that we all kind of know, but now we're seeing it and we have the ability to use it and expand on it. So thank you, thank you, thank you. And to all of you on the panel who fleshed out and gave so much more information about the relevance of these data, what we can do with them, and made me write a lot about all sorts of ideas. So I wanted to touch base with all of you after this. And to the Boston Foundation for providing the support for this project and this space to have people come, and to you in the audience to listen and interact with it. So it is as a researcher and an academic, this is like so satisfying to be here right now and to use these data, not to wait to publish an article, nothing against publishing articles, but so I want to thank you so much for that. So just really quickly, I want to say a couple of things that we know, those of us who have been doing this work for many years, and luckily we have had research, 40 plus years of knowing that it matters what happens in a young child's life. So I'm not needing to tell you about that. And we have local people, you know, names like Raj Chetty, Dolores Acevedo Garcia, who were also saying that the environment matters for where young children are growing, the neighborhoods they live in. We have neighborhood level data. The schools they attend matter, and the resources that are available. All of that matters in some very specific way. And so what you demonstrated is that one resource for young children is, you know, the resource of infant early childhood mental health providers, and training that workforce and making sure that that workforce is robust and taken care of in all of the ways that you detailed is going to allow us to have the people power, really the people power to address the needs of all of the young children in the Commonwealth. And particularly, you know, I want to say that those young children that are living in marginalized communities have least access to resources, and so we are always keeping them in front of our mind. So, you know, you each commented on some of the take-home points, and there are even more, but I want to call out a little bit of course, increased wages. We're not going to keep anybody unless we pay people living wage and maybe even beyond that, so that people can continue to do the work, because I think the quote from the person you talked about, Alicia, who said you can work in Target and Walmart and make more money. I mean, it's just a no-brainer. No matter what we do, I don't think we're going to be able to keep people. And the training piece, so thank you, Alicia, for mentioning that. Yes, Aditi and I have been talking about this and putting things together. And we have models of this, actually. And so I do want to say that in addition to being a professor at the School of Social Work, I'm the Associate Director for Research we have an Institute for Early Childhood Wellbeing at Boston University. And we have been thinking about ways of launching platforms that are accessible across the state. And we have models of doing this actually in the aging workforce. We do host platforms that many states use. And so there's models for that. So to the person who asked that question, happy to talk about that more. In terms of training and the one-stop hub, I've already said about that. People with lived experience, we're doing that, right? I mean, we're doing that. So ways of supporting people, I think we can look to what's happening with community health workers and also peer recovery coaches within the addictions field, which is something that I do a lot of work in. We have lots of models for supporting people, for getting people levels of sort of licensure and stuff that I think somewhat kind of legitimizes the work in ways for people with lived experience. And I think that's actually something that we should consider. And in terms of addictions and substance use, for so many of our young children, particularly those involved in the child welfare system, that's the reason that they're there. We in Massachusetts have numbers of programs. We have the capacity to train everyone in understanding what parental addiction means for very young children, what happens in families, ways of being supportive. So again, another thing that I'm very personally connected to, and we do have lots of that capacity. So it pained me to see those little vacuums, and we tried to get people to respond, but something to think about. Right now, actually, the Association for Maternal Child Health Programs, they were funded by Peregrine to develop a perinatal substance use disorder kind of block of different types of interventions, from prevention to treatment. And right now, until Friday, they have an LOI open where you can actually get money to train people in one of these models, and 2 are from Massachusetts. So it's live, happening right now, and if you want to know more about it, I'm happy to tell you about that. So I just really want to end with a quote that I made. The findings made me think about this, and I need always a little inspiration to keep you going. And this is from Gabriela Mistral, who's a Chilean Nobel laureate. You may have heard of her. And she said, "Many things can wait, children cannot. Today their bones are being formed, their blood is being made, their senses are being developed. To them we cannot say tomorrow." So I say today. Thanks very much.